Bismillah ar-Rahman ar-Rahim. Management of rheumatoid arthritis, RA. The treatment is aimed to suppress inflammation, control symptoms, and prevent joint damage. This involves a combination of drugs therapy and non-drugs therapies. Drugs therapy are 1. Non-steroidal anti-inflammatory drugs. 2. Disease-modifying antirheumatic drugs. 3. Glucocorticoids. 4. Biologic therapies lines. So 4 lines of therapy. Shall start with non-steroidal anti-inflammatory drugs. Many patients presenting with early arthritis or polyarthritis may have self-limiting or benign course. Arthritis. Such patients require only temporary relief of their symptoms by the use of non-steroidal anti-inflammatories only. Non-steroidals don't alter the course of the arthritis. There are two COX isoforms, COX-1 inhibitors and COX-2 inhibitors. COX inhibitors with upper GI tract ulceration and bleeding perforation complications, as they damage gastroduodenal mucosal barriers. Dyspepsia is a poor guide to the presence of non-steroidals associated ulcerations and bleeding. Non-steroidals are much less likely to cause GI bleeding. Co-prescription of proton pump inhibitors reduce the risk of non-steroidals and induced bleeding and ulceration. So it is better to give proton pump inhibitors with all non-steroidals, including COX-2 selective non-steroidals. Other side effects of non-steroidals include fluid retention and elevation of blood pressure. So blood pressure elevation is one of the complications of non-steroidals use. Renal toxicity, بين قوسين analgesic nephropathy, renal impairment, skin rashes and asthma, and even anaphylactic shock, which is rare, very rare. Non-steroidals should be used with caution in all patients. Avoid use of non-steroidals in patients with vascular diseases. Non-steroidals potentiate the anticoagulant drugs and the oral hypoglycemic drugs. Non-steroidals may cause dyspepsia, GI bleeding. Aspirin may cause tinnitus, Phenylbutazone may cause blood dyscrasia. Indomethacin causes fluid retention and headache. النهاية القائمة the commonly used non-steroids and their risk of gastrointestinal bleeding and perforation. صفحة 1003. It is categorized into low risk, medium risk, and high risk GI bleeding and perforation for the non-steroids. القائمة لازم تنحفظ. The other line of treatment is the disease-modifying antirheumatic drugs, DMARD. These are drugs of immunoresponse inhibitors. But they might be used in inflammatory rheumatic diseases and other inflammatory diseases. They are slow-acting drugs, needs at least 8 to 12 weeks to show their benefit or action. If they did, شهرين إلى 3 أشهر. They are more toxic than non-steroidals. Most of them may cause bone marrow suppression and hepatotoxicity. They may cause renal impairment, renal toxicity. The use of disease-modifying anti-rheumatic drugs require regular monitoring of liver function test, renal function test, blood monitoring, and if toxicity occurs, one have to stop treatment temporarily and later resumed reduce its use to a lower dose. But if toxicity is severe, therapy should be stopped completely and another drug substituted. Disease-modifying antirheumatic drugs are not analgesic drugs. They are not analgesic drugs. So non-steroidals should be co-prescribed with disease-modifying drugs to start with. They are more toxic than non-steroidals, so should be used only when the diagnosis is solid, not for probable cases. Their mode of action is not fully understood. They are used when the diagnosis is solid and there is an active arthritis for more than 6 weeks. Methotrexate. Methotrexate, MTX, is the most used disease-modifying anti-rheumatic drug. Its action may appear after 4 to 6 or 8 weeks if it does occur. So MTX is more rapid in action than other disease-modifying anti-rheumatic drugs. MTX is given as once weekly doses, already 7.5 milligram up to 15 milligram, 7.5 إلى 15 once weekly. Or if gastritis does occur, one may give it as subcutaneous or intramuscular weekly doses. Mtx is a folic acid analog, so folic acid prophylaxis should be used to reduce side effect. Folic acid is used as 5 mg tablet the day after or 1 mg daily. Folic acid. Mtx may cause bone marrow suppression, hepatotoxicity, so blood counting and liver function monitoring should be done. A drug interaction with sulfonamide and other folic acid antagonists should be avoided. Mtx may cause nausea, diarrhea, stomatitis, fatigue, alopecia, elevated liver enzymes, pneumonitis, and liability to infection. Mtx is contraindicated during pregnancy because it is teratogenic agent. الجدول مال disease modifying antirheumatic drugs page 1004. On the top, methotrexate. Second, sulfasalazine, hydroxychloroquine, antimalarial, and others. A few words on biologic therapy. Tumor necrosing antagonist, TNF, and infliximab is usually used. They are more toxic than the disease-modifying antirheumatic drugs. No. The other line of treatment is steroid therapy. Steroid might be used locally, or we may use systemic steroid therapy. Locally, corticosteroids may be injected one intra-articularly inside to the joint, 2 intrabursal injection, 3 under tendon sheaths. Intra-articular steroid therapy to arrest actively inflamed joint or joints, inadequately controlled by systemic drugs therapy. This intra-articular injection should be used under strict aseptic precautions, otherwise iatrogenic septic arthritis may be induced. Iatrogenic means medically induced. Now, intrabursal injection, and we have under tendon sheath injections. These are local steroid injections. Steroids, corticosteroids, also may be used systematically. Systemic steroid therapy might be used with the treatment of rheumatoid arthritis as a bridge therapy in combination with disease-modifying antirheumatic drugs during the first period before the initiation of beneficial action of disease-modifying drugs, as they need 2 to 4 months to have their action. Otherwise, long-course systemic steroid therapy have too many side effects. and it is one of the drug abuse such a use. So the side effects, now a few words on the side effects of corticosteroids. Side effects of corticosteroids, we have musculoskeletal side effects, muscle atrophy, osteoporosis, liability to fracture, avascular necrosis, 2. Liability to infection, pulmonary TB, UTI, poor wound healing, septic arthritis. 3. Hypertension, retention and edema. 4. DU, GI bleeding. 5. Glucose intolerance and hyperglycemia, and reduce glucose tolerance and hyperglycemia and diabetes mellitus. 6. Cataract, intraocular, increase intraarticular pressure. 7. Psychosis. 8. Skin atrophy and changing the fat distribution, abdominal striae, moon face, and pituitary adrenal suppression. كلهم يصير 32 side effects. Now, how to use disease-modifying antirheumatic drugs for patients with firm, strong diagnosis of RA for more than 6 weeks with active disease. One should use disease-modifying antirheumatic drugs. Usually we use Mnx, methotrexate, in weekly doses combined with non-steroidals plus glucocorticoids, systemic steroid therapy, parenteral or oral prednisolone, which should be reduced gradually to be stopped after 12 weeks. In most patients, this is called steroid bridge therapy. Mnx may be increased to a maximum of 25 mg weekly, depending on the patient response. If patient fails to respond or dose-limiting toxicity occur, then an additional disease-modifying drug should be used. Usually we shift to triple therapy, which is methotrexate plus sulfasalazine plus hydroxychloroquine, the anti-malarial. Sometimes one may add prednisolone 5 to 10 mg daily doses. After that, if still the patient not responding to therapy and disease activity score is still high, يعني DAS 28 more than 5.1, one has to shift to biologic therapy. Usually we use tumor necrosis factor antagonist inhibitors, infliximab with more toxicity and side effects. The general measures in the management of rheumatoid arthritis, we have the rest, we have the physiotherapy. In the physiotherapy, we should the principles of include strengthening the muscle groups controlling the affected joints, prevention of deformities, and re-education in the use of damaged joint. Joint diseases produce wasting of nearby muscles. In weight-bearing joints, this leads to instability and increased mechanical stresses, which in turn produce more joint damage and pain. For example, wasting of the quadriceps muscle in the knee joint, arthropathies, one can modify this wasting by static exercise, يعني isometric exercise, while the knee joint remains fully in extension or in a splint. Sometimes one may use heating physical modalities for their analgesic effect. Regular prone lying is very useful to prevent flexion contractures of hips and knees. Appliances, aids and devices, for example, walking sticks, عصاية, or a crutch, عكازة, may be used on the opposite side of the inflamed hip or knee to reduce weight bearing. While in severely disabled patient, wheelchair, كرسي متحرك, may be used. Also, we may use cervical collar, الياقة العنقية, splints for knees, wrists, special shoes, insoles, etc. The last line is surgery, like joint replacement surgery, excision of metatarsal hairs in patients with severe MTP subluxation in the feet, and neurosurgery for atlantoaxial subluxation. Supportive therapy. Supportive therapy advise patient to take calcium and vitamin D to prevent osteoporosis. Serum lipid profile examination and treatment of hyperlipidemia, and also the treatment of anemia. Causes of death in rheumatoid arthritis: atlantoaxial subluxation, faulty syndrome, amyloidosis, renal failure, especially iatrogenic due to nephrotoxicity of nonsteroidals. Prognosis is variable. Juvenile idiopathic arthritis. This term is used when we have an arthritis for more than 12 weeks, definite arthritis for more than 12 weeks in a patient of less than 16 years of age, أقل من 16 سنة. Clinical features of juvenile idiopathic arthritis. It is of several subtypes. We have the systemic juvenile idiopathic arthritis with fever, rash, arthralgia, and hepatosplenomegaly. We have the oligoarthritis, and we have the polyarthritis. Polyarthritis is divided into oligoarthritis when we have 4 or less joints are affected. Polyarthritis when we have 5 joints or more joints affected. Polyarthritis is divided into seropositive, يعني rheumatoid factor positive polyarthritis, and we have the seronegative polyarthritis. Types or patterns of juvenile idiopathic arthritis. 1, we have the systemic. 2, we have the polyarthritis or polyarticular, when you have 5 joints affected or more. This is divided into seropositive rheumatoid factor polyarthritis or seronegative polyarthritis. The seropositive polyarthritis usually might be considered as a juvenile rheumatoid arthritis, and many of them later on may pass to rheumatoid arthritis if they pass the age of 16 years of age. Now, the post-articular polyarthritis might be also divided into early onset and later onset. Early onset usually in the age of 5 years only, and late onset in the adolescent, 12 years and so on, and like that. Early onset have the risk of uveitis of the eye, with the risk of blindness. Other forms of juvenile idiopathic arthritis are the psoriatic and inflammatory bowel disease and connective tissue diseases with juvenile idiopathic arthritis. القائمة هي المعتمدة. It is more easy. The management of juvenile idiopathic arthritis are by the general measures, rest physiotherapy, and by the drugs, non-steroidals, intra-articular steroid, and by the use of disease-modifying antirheumatic drugs. Oligoarthritis is the most common form of juvenile idiopathic arthritis, occurring for about 60% of cases. Systemic occurs only in 5% of patients. The risk of uveitis, and we have the risk of arresting of joint development. Treatment are by the non-steroidals and by the disease-modifying drugs. Inflammatory arthritis in children affect the growth of the joint and affecting the limb growth. So effective control of the inflammation is important. Affecting limb growth, and it has a negative effect on height and weight of the patient.